So I'm Becki, I'm the vague symptom clinical nurse specialist here at the Royal, and my job is to act as the key worker for them patients that have got a suspicion of cancer.
So my name's Georgia and I'm the support worker here at the Royal for the Rapid Diagnostic Service.
So vague symptoms are non-specific symptoms that when a patient presents to the GP, they have a suspicion of cancer, but they could have multiple symptoms that don't fit a clear defined pathway. This can be abdominal bloating, nausea, vomiting, loss of appetite, weight loss, night sweats, or a typical lump that doesn't fit a pathway. They come under us.
We are a pathway for the primary care in the community, and they refer to us when there's not a specific pathway here to go into the hospital.
So we cover Central and South Liverpool, and we find that our pickup rate is about 13% for cancer. Obviously, like a pancreatic cancer, you can look at the liver blood tests will be elevated. They sometimes have night sweats, they have loss of appetite, weight loss, abdominal bloating. But there's certain cancers that are quite non-specific in the symptoms that we diagnose. Seems to be lung cancer is quite prevalent in our area. We do see a lot of HPV, so gallbladder, pancreatic cancers, but again, they're quite hard to diagnose cancers.
So the GPs in the community will refer to us via e-referral, and when that happens, myself as the support worker, I will print it off, make sure all the mandatory bloods are done. If they're not, speak to either the GP to get them done, or we will organise that. The CNS, Becki, will organise that for the patient to come into the hospital. And then we have a telephone assessment, which usually takes around 35 minutes. Becki does the medical side of stuff, where I can ask for basic symptoms, what they're experiencing, the social history, the mental health as well.
And we get their full history from the GP and all investigations. We then pick it up, and the GP can see exactly where on the journey the patient is from e-referral, so they can see when the telephone assessment's booked for, when they'll go to MDT, when they'll have the scan. That all information is on the e-referral system. The patients that don't have a cancer diagnosis, we refer them on to the appropriate specialty. Now, sometimes what we're finding is that the patients have medically unexplained symptoms, and that's again linked to mental health, so we will refer them into mental health as appropriate. Every patient is as important as the other, and if we get a diagnosis of anything, we will refer them on to the appropriate team. We develop quite a close bond to our patients because we speak to them regularly during their time on our pathway, and I guess it's just having that someone to listen to them. We have got more time than the GP is, so we have that initial 35-minute conversation with them, and then they can ring us anytime, and so it's just knowing that someone's listening and someone's there for them at the end of the phone and listening to their concerns.
I'd like to see ourselves as a comfort blanket. We're there to reassure them that they will get sorted, they're not going to be left in limbo as such, and we will be there to help them and give them the diagnosis that they need to move on with their lives.
It's knowing that there's a key point of contact, and when there's patients out there with so many non-specific symptoms and you think, do I put them on this pathway, that pathway? Well, ours is just that one single point that you can refer in, and we do the coordination and transferring of care with it, and you just know that someone's looking after your patient.
We do build up a rapport with the patients that they can trust us, and we are there for them. We've got real good relationships within the hospital and within the community as well, that we can mix it all together and get the patient sorted. We get things done, and we don't stop till we get the answers that we need.